if both heart and lungs stop working. He suffered a cardiac arrest. The person who has had a cardiac arrest will collapse, lose consciousness, and when you feel, there will be no pulse and no breathing. Cardiac arrest is an emergency which needs immediate intervention, and if we want to save the patient's life. And the process by which we try to restart the arrested heart is called CPR, or cardiopulmonary resuscitation. Cardiopulmonary resuscitation has two components: the basic life support, which constitutes of life-saving skills which are easy to learn and can be taught even to laypersons. So today we are gathered here to learn that, because every member of a healthcare facility should be well versed with basic life support. Because in our campus, people with various diseases will be moving around, and what time they will go into a cardiac arrest, we don't know when such an incident can happen. So all of us have to be prepared with that training. Then the second component is ACLS, or Advanced Cardiac Life Support, which includes specialized skills like endotracheal intubation, securing IV access, drug administration, cardiac monitoring, rhythm assessment, and defibrillation, which is done by a team of specially trained doctors, nurses, and technicians called the Code Blue team. And so at your city centers, after this training, you all have to make a Code Blue team which will be responsible for taking care of such cardiac emergencies. And today here we are focusing on BLS protocol and skills. So what are the two main components of BLS? They are the chest compressions and the rescue breaths. Chest compressions to pump the heart manually and keep the blood circulating to the brain, and rescue breaths to push air into the lung and from there into the blood so that it reaches the brain. So in other words, we are trying to keep the brain alive. After cardiac arrest, the brain normally will die within 4 minutes. So the main goal of BLS is to keep the patient alive by providing oxygen to the brain till advanced life support arrives. The knowledge of BLS, with the knowledge of BLS, all healthcare providers will be able to respond immediately and do CPR till the Code Blue team arrives with specialized help. So who are these people who can do the BLS? So any medical or non-medical volunteer who wants to undergo the BLS training can do the BLS. And persons who respond first to provide BLS to an arrested person is called the first responder. Supposing some incident has happened and you reach there first and you know BLS, so don't run away. You should immediately start providing BLS to that person, so that, because the first few minutes are very, very important, and that is the time, if you don't respond at that time and you waste the first few minutes, then the chances of survival become very less. So what is the first responder duty? To assess the scene safety. You must see that there is no hazards like fire or live electric wire nearby, or some broken glass or things like that, so that you can shift the patient away from that and then provide the BLS. Then assess patient responsiveness. So the second step is to assess the patient responsiveness, whether he's responding or not responding. If he's not unresponsive, then you see whether he's breathing, and immediately you call for help. See, the person, what you would say when you call for help, you have to particularly point out at somebody or take their name and tell that please so and so announce Code Blue. Okay, so ask ask someone to dial 333 and announce code blue and activate the code blue team so that they will come to your help as early as possible. And in the meantime, this person is also supposed to bring the crash cart which is nearest, which is located nearby, and also if that is not available, at least the AED machine which is near. Now, the first responder has to remember the mnemonic tab. So, circulation is the first thing we are looking at, then the airway, whether it is open and clear, and the breathe, whether the patient is breathing. Take 5 to 10 seconds to identify the cardiac arrest by checking the pulse. Place the tip of your fingers over the thyroid cartilage and slide them down into the groove between the trachea and the sternocleidomastoid to feel the pulse. Do not take more than 5 to 10 seconds. In infants and small children, it is preferable to check the brachial pulse or femoral pulse. So all this pulse checking technique and all will be taught to you hands-on, so we won't go into more details, just briefly. Then you start, you find that the chest pulse is not there, that means the heart is not working, and immediately you have to start the chest compressions. Chest compressions, 30 compressions constitute one cycle, and the rate should be 100 to 120 per minute, and the depth 2 to 2.5 inches, or we can say 5 to 6 centimeters. So first, you have to interlock your hand, keeping the dominant hand below and placing the other hand on top of it and interlocking in this way. And this is the heel of your hand. The heel of your hand has to be placed on the sternum, on the imaginary line joining the two nipples, and then you start giving the chest compressions. To give effective compressions, keep the elbows and shoulders straight. See how it is straight, and bend, you have to bend from the hip. So the movement of bending and pumping should be from the hip. Allow complete chest recoil between the two compressions. Give 30 compressions at one stretch, which will constitute one cycle. And do not interrupt chest compressions for more than 10 seconds. In children, you can use only one hand, because maybe when you use two hands, that will be too much for a small child and you may break their bones. So pressure with one hand will be enough. And in this, the depth has to, the rate will remain same, 100 to 120 per minute, but the depth of compression will be 4 to 5 centimeters, that is 1.5 to 2 inches.
Infant is below 1 year.
In infants, the chest compression techniques are either a single hand when there's a single rescuer, or two thumbs encircling technique, which we can use when there are two rescuers, one to give the chest compression and one to give the breaths. Here, the depth of compression should be not more than 1.5 inches, or more appropriately, it should be 1/3 of the anteroposterior diameter of the chest. After every 30 compressions, which we will count loud, 1, 2, 3, 4, like that. And when we complete 30, after that we have to give 2 breaths. 2 breaths should not take more than 10 seconds. When you are scanning the patient for breathing, you can hear the sound of breathing. If it is absent, and looking at the chest, you will be able to make out whether the chest is moving or not. Now, before giving breathing, what you have to do, you have to see that the airway is patent. So you do head tilt chin lift. So this technique, here you can see in this technique, this is head tilt chin lift technique, where you keep one hand on the forehead and with the other hand you push the chin up and straighten the airway so that the patient's airway becomes patent and straight. If there is a doubt of any cervical spine injury, then we use the method of jaw thrust. All this will be demonstrated in your hands-on class. Before giving the breaths, You must also see if there is any secretions. You have to clear the secretions with the suction apparatus using the hard or soft cannula appropriately. And then you can give rescue breaths in 3 ways. One is the mouth-to-mouth rescue breath, in which you have to pinch the nose and blow into the patient's mouth. And because you may get some infection from them, that is why you should wear a surgical mask or keep one surgical mask in your pocket, which you can, or any cloth, handkerchief, only anything which you have available at that time, keep it between the patient's mouth and your mouth. Because if nothing is available, this is the best option to give the breath. Sometimes, as Dr. RNR says, if then you have hesitation, then continue with the chest compressions and do not give the breaths. You can continue doing chest compressions continuously, but that is not what is expected from healthcare providers. That is basically for the lay persons. Then we also, the core blue team normally will keep the pocket masks in their pocket, and whenever such a occasion arises, you can give mouth to mask respiration. So you can see how the person is holding the mask with 2 hands and tightly fixing it to the around the mouth of the patient. This will cover mouth and nose both. So here you don't have to pinch the nose, and then you can blow it. So each breath should take will take only 5 to 6 seconds. You take a deep breath and blow for 1 second. So you 1, 2, 3, 4. You take the breath and then blow for 1 second. That is how you deliver mouth to mouth or mouth to mask respiration. The best technique, and especially when the person who is helping you has come with an ambu bag, this ambu ventilation is one of the very important methods of giving positive pressure ventilation or rescue breaths to the collapsed person. So in this you can see there are 2 techniques. 1% technique where with one hand the person is holding the mask, which is triangular in shape, and the base of the triangle is placed on the chin, and the apex of the triangle on the nose, and then we are holding it down with the CE grip, and with the other hand he is pressing the collapsible bag, that is the ambu bag, and to deliver the breath. Now, this is it is more effective if 2 people are available to do that. One person holds the mask with both hands, so that the fixation of the mask is very firm and there's no leakage of air, and the other one delivers the breath by squeezing the bag. So as we will demonstrate, you will see that the ambu bag has a face mask and a valve, a one-way valve, where the exhaled air does not go back into the bag, and then there is an inlet where you can attach the pipe through which oxygen can also enter the bag, and there is a place where you can put the reservoir where the extra oxygen will be stored. So if once we give the 2 breaths, so 30 compressions and 2 breaths constitute 1 cycle of CPR. We repeat such 5 cycles to make 1 round of CPR. And 1 round of CPR should not take more than 2 minutes. So we have to complete these 5 cycles of CPR within 2 minutes. And after every round of CPR, you have to check the carotid pulse. If the pulse is not there, you continue the CPR. And as soon as the AED machine arrives, the AED machine is the automated external defibrillator, which acts like a cardiologist for us and tells us what is the rhythm of the patient. And once we assess the rhythm, and if it is a shockable rhythm, we immediately deliver the shock. The earlier we recognize the rhythm and deliver the shock, the more the chances of survival. That is why at the very outset, the person who had announced code blue has gone to press the AED machine. Now, once the AED machine arrives, immediately you attach the AED machine. So this is the AED machine, which has an on button and a shock delivering button, and has here you will have these multifunctional adhesive pads on which you can see that it is drawn how to, where to fix the pads. So one is below the right clavicle and the other is below the, on the left lower chest, below the left nipple. So you appropriately fix the pads and then attach the cable to the AED machine. And once it is fixed, then the AED machine is switched on. Once you switch on, then you fix these pads, and the AED machine will say that pads inserted. Once it is, then it will say assessing rhythm. Now, once you start the machine, it starts talking. By itself, it will tell you fix the pad, fix the pads to the bare chest, attach the cable. So all these things it will go on saying by itself. And once it says assessing rhythm, then you all have to stay away from the patient, because at that time it may make a mistake in assessment if we are doing the CPR. So we have to stop the CPR temporarily, and the AED machine will, if it will assess the rhythm, and if it is a shockable rhythm, that is, if it is a ventricular fibrillation or a pulseless VT, then immediately it will say preparing for shock and it will charge. Once it is charged, the red button will start glowing and it will ask you to press the glowing red button. Before pressing the red button, what do you have to say? You have to say, I clear, you clear, all clear. Nobody should touch the patient. And you should press and deliver the shock. And after delivering the shock, the machine will again tell that shock delivered. Now it is safe to touch the patient. At that time, you will start the CPR once again. Okay. If after, so every 2 minutes, the machine will assess rhythm, and in these 2 minutes, you have to do one round of CPR. After another round of CPR, if the machine says that CPR shock not required, then what can be the conditions in which shock is not required? Either it is a non-shockable rhythm, it is asystole or PEA, or the patient has a normal sinus rhythm. So how do we know whether the patient has return of spontaneous circulation? So we have to check the pulse. If the machine says shock not required, we have to check the pulse. If pulse is not there, then we have to again resume CPR and continue doing this process till the code blue team arrives. Okay? So I just wanted to show you that this is the ECG of normal sinus rhythm. For some people like the nurses, this is a very important thing. And we have four rhythms when the patient has cardiac arrest. It could be a ventricular tachycardia. Here you can see the complexes. You saw in the normal sinus rhythm that the QRS complexes are narrow and they have a very there's a particular pattern where the P is followed by a QRS and then a T. Here, when we have a ventricular tachycardia, the complex is broad, but they are all equal, and the rate is very rapid. The complex is broad, but they are all same size and looking alike. Okay, in ventricular fibrillation, you have a rapid rate, the complexes are broad, but all the complexes are not looking alike. Some are small, some are tall, some are thinner, some are fatter. Okay, so it is all irregular. And so VT is always VT and VT without pulse and VF are always shockable rhythms. Then you have the asystole, where there is a straight line. Okay, and this is a non-shockable rhythm where you have to continue CPR. And this is PEA, where there is some sort of a rhythm, but it is not causing enough to give us a pulse. So it is called pulseless electrical activity. And so I just went through these 4 rhythms so that you will know what are the rhythms in cardiac arrest. And the 2 rhythms which are shockable are the VT and VF, and the 2 rhythms which are non-shockable are the asystole and PEA. So your AED machine recognizes VT and VF, and if required, it will prepare for shock. And after shock, you may find that your patient has come back to the sinus rhythm. Okay? And got back the pulse and you have saved the patient. So what do we do after defibrillation? We restart CPR, which I already told all this. If supposing the pulse has come back, you shift the patient for medical management, and if the pulse has not come back, you continue CPR till your whole team arrives. Then time management. So this is something very important. You have to assess scene safety. Don't take too much time. You have to do it very quickly within a few seconds, and then shift the patient and start. And 5 to 10 seconds to identify that the patient is responsive or not responsive. And then once you start the compressions, 100 to 120 per minute, and it should be the rate, and depth should be appropriate as per age. And 10 seconds or less for interruption of chest compression, that is hands off time should not be more than 10 seconds. And in this hands off time, you can do 2 breaths, you can check pulse, you can switch roles, all this can be done in this 10 seconds. Then for adults, 1 breath is given in 5 to 6 seconds, for infants 3 to 5 seconds, and the code blue team is expected to arrive within 2 minutes. So I hope all of you, once you learn the basic PLS skills here today, will be able to handle any emergency for those 2 minutes till your code blue team arrives. This is just, we will not go through this just now. Universal precautions will all, you all should wear gloves and keep surgical mask in your pocket. So another very important emergency which you will face on and off in the campus or at home also, when small children sometimes put things in their mouth, or while eating suddenly you start choking. So if a person is choking, that is when a foreign body gets stuck in the upper airways so that it obstructs the flow of air into the lung, that is called choking. And if we are not able to relieve the choking and restore breathing, it can lead to cardiac arrest. So a patient who is choking can be responsive or unresponsive. If the patient is unresponsive, means he already has gone into cardiac arrest and we have to start CPR. But if the patient is responsive, and then we have to, as per guidelines, we have to see whether there are signs of severe foreign body obstruction, that the patient is not able to cough, not able to speak, and is getting change of color, that is getting cyanosed, and he is little drowsy, and is having difficulty, he is not able to breathe at all, then immediately we have to give 5 back slaps, okay, and 5 abdominal thrusts, which is called Heimlich maneuver, which will all be demonstrated to you at your particular stations. And the same thing for children, if we give 5 back slaps and followed by 5 chest compressions, this also we will be demonstrating later. And if you successfully remove the foreign body, are able to get the foreign body out of the patient's airway, and you will save the patient. So thank you for helping us save a precious life.